And good afternoon. I'd like to welcome and introduce Dr. Robert Murphy, Executive Director of the Robert J. Havey, MD, Institute for Global Health, and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine, who answers your COVID questions and addresses the latest in COVID news every Tuesday and Thursday here on the Havey Institute for Global Health Facebook page. And today, Dr. Murphy will be answering viewer-submitted questions and addressing the latest news that we've received through today, the 14th of October. And we invite you to continue to submit your questions to us via Facebook at NU Institute for Global Health or via email at globalhealthinstitute@northwestern.edu. And leading the discussion again today is our very own student research assistant, Sophie Paskowski. So Sophie, I now turn it over to you.
Hi, Dr. Murphy.
Morning.
So for some updated statistics, in the United States, 56.8% of the population is fully vaccinated, which is awesome. And we are now hitting a 7-day average of under 100,000 daily cases, so 91,399. This has been a 21% decline in cases over the last 14 days. In Florida and Texas, we're seeing a massive decline, but in Guam and Minnesota and Alaska, we're still seeing a huge incline. In Minnesota, there's been an increase of 35% cases spike, which is very unfortunate. And in Illinois, we're continuing to see a decline. In the 7-day average, there was 2,431 cases, and we now have 54.3% of the population in Illinois fully vaccinated. What can you tell us about this increase in cases in Guam and in Minnesota and Alaska?
Yeah, no, so the overall figures are going down worldwide and in the United States. However, there are still hotspots. And in Alaska, they have really lax mitigation policies in place. So that's really not a big surprise. And Alaska is pretty isolated from the rest of the United States. And they're having a terrible outbreak. And they're having, the hospitals are swamped. The medical professionals taking care of the sick patients are really struggling to keep this under control, while many people in the population are still fighting against even wearing masks, let alone taking a vaccine, and they're low on the vaccine. What doesn't make any sense to me is what's happening in Minnesota. They have actually a fairly good vaccination rate. It's in the upper 50s, but they're having this terrible outbreak in Minnesota right now. And so actually, from an epidemiological standpoint, this is not too surprising. There's still too many people at risk out there, children under 12, all the people that won't take the vaccine. There's still, a lot of mingling with unvaccinated and vaccinated. And so this is just a lesson of what's going to continue to happen if we don't get the vaccination rate way up. I mean, our goal now is really 90%. And so we've got a ways to go. Now, the kids are going to come on board very soon, because it's likely that under 12, from the 5 to 11 age group is going to get approved. And even the younger kids will get approved probably in a couple months. So that's going to help a lot. But this epidemic is not over.
Well, that's very unfortunate to hear. And for some headlines from the last 2 days, there's been many of them. So one of the big ones is that the US will reopen land border in November for fully vaccinated individuals. What is this going to look like with travel?
Well, this will be internationally the rule. It already is the rule in many places. And this is just going to continue to tighten up. If you want to travel internationally, you're going to have to be vaccinated. You show your vaccine card when you get your visa, or whether you're in a visa-free situation like to Canada or Mexico, you're going to have your vaccine card to move between the borders. So anyone that does that kind of international work, wherever it is, or for travel, for pleasure, whatever, you will have to be vaccinated. So this is just going to be the way of the future.
Yeah, it's very interesting. And the FDA stays neutral on the need for the Moderna booster. Can you tell us about the boosters and what you're seeing with that and what that's going to look like?
Well, there's been a really huge amount of information in the last 48 hours about these booster shots. We already got approval now for to give a third shot to anybody who's immunocompromised. So really severe immunocompromised conditions like kidney transplants, high-dose steroids, any kind of immune suppressive therapy, they can just get another dose. That's not even considered a booster. Some of this is just terminology. So that was the first one. Then Pfizer showed they had decreasing clinical effect and antibody levels. And that booster was approved in the last 2 weeks for people over 65, people under 65 with underlying medical conditions that put them at high risk, and for quote, essential workers. And you can define that however you want. But anyway, so that booster, that was just Pfizer. Then the FDA is meeting today and tomorrow. And then the CDC will meet and review the same thing again next week about Moderna and Johnson & Johnson boosters. So the preliminary data are that the Moderna information on their booster is that the booster, the data that they presented was didn't show much of an effect because those people had a pretty good effect anyway. So in other words, the reading between the lines, it looks like maybe the Moderna people don't need a booster at 6 months. Maybe it's going to be 12 months or 24 months or whatever. This is science. We're learning a lot about this stuff. Johnson & Johnson, then the other question about Moderna is it going to be a half a dose or full dose? So currently they're looking at full dose, but they're studying the half dose because that may be plenty. And they're hoping that there's 2 reasons why they want to do the lower dose. One is that they'll have a lot more vaccine to give out because that will basically double their output in number of doses. So that would really be great worldwide, that they could get more out there. The other thing is that countries in Europe, Denmark included, are now limiting Moderna. They're not allowing Moderna to be given to younger men. I believe the age is 30 years of age because of the slight increase in incidence in myocarditis, the inflammation around the heart. So maybe a lower dose would have fewer side effects, but we don't even know that. It might not even be the dose at all. But anyway, so that's the situation with Moderna. With the Johnson & Johnson, they presented the data. It's been reviewed. And the FDA really complained about the methodology of them measuring the effect. Certainly we know that the Johnson & Johnson vaccine does not have the same clinical protective effect that the mRNA vaccines have. That's Moderna and Pfizer. So, the rate of hospitalization and death, hospitalization in particular is lower with those. The death rate appears to be about the same, but there's more clinical events. So they gave data showing their booster data was 2 months and longer, so it was a wide range. But the FDA didn't like the methodology that they used to make their case. So all that is going to be resolved, presumably, today, because the FDA is meeting today and tomorrow, and they'll have their report out, and the CDC will meet looking at the same data and with the opinion of the FDA next week, just like they did with the Pfizer booster. So we'll have some information about that. The other big news that came out is this kind of mix and match approach. So you get one vaccine, you get your first couple vaccines, the first 2 doses of Pfizer or Moderna, or the 1 dose of Johnson & Johnson, and then you get boosted with another one. So the NIH funded a study with 9 different groups with about 50 in each group, 450 patients total, getting, at the baseline in their first vaccines were either Johnson & Johnson, Pfizer, or Moderna. And then one group each group then got boosted with either of the, with actually both of the other ones in different groups. So it's a beautiful little design, and it's complicated. It's out there now in a preprint that anybody can download. I downloaded it myself this morning and printed it out. And it showed that the most striking feature was that in the case of Johnson & Johnson, the getting boosted with the mRNA vaccine created a lot more antibody level, significantly more, particularly with the Moderna. And that everybody, improved more, but the boosting with the mRNA vaccines was definitely more striking.
Right.
And so we'll see what happens with that. That's preliminary information. So we don't even know, we don't know the full report yet. So that's, I think, the day 15 analysis, and they have a day 29 coming up. But I think it's very important information because we're just learning more and more about what's the best strategy here. Maybe the Johnson & Johnson is the best one to have up front, because after one dose, the results are the best with the Johnson & Johnson. But with boosters or second dose, it looks like it's going to be the Moderna. Now, that study that I'm just telling you about is not really a booster study, because people got the vaccines, these booster doses at a variety of different time points after the first vaccine. So it wasn't really even boosting, but it is an additional dose. So you're going to see a lot more about that in the next couple of weeks or months when that full data set comes in. But I think it's great that we're learning more and more about the optimal strategy to keep people protected.
Yeah, absolutely. And speaking of learning, the White House is telling states to prepare for COVID vaccinations in young children. So what can you tell us about this preparation of the White House talking to pharmacies and medical companies?
Yeah, well, I mean, they're just getting everybody ready for this, most likely an approval in the 4 to 11 group that they had said was going to be sometime in October. So we're right in the middle of October now. So probably in the next couple of weeks, that'll be great, because that'll basically be all school kids. And then in the younger kids, that's likely not to come until early 2022.
Wonderful. And lastly, the Texas governor bans COVID-19 vaccine mandates from any employer in the state. What can you tell us about this banning of mandates by the governor?
Well, he's going to be overruled by the federal people that have to follow federal guidelines. He can't go over those particular guidelines in a federal situation. So travel, interstate travel is governed by the feds. So the airlines and stuff have to follow the feds, and they've said, we have to follow the federal guidelines because we're interstate travel. So, it's just this pathetic policy of, just ignoring the facts that these vaccines are very important in controlling the pandemic, and that the mandates are working. And places where the vaccine rate goes way up, there are a lot less cases. And this is the best way to fight the pandemic. It is a pandemic, and it's killing people. Over 700,000 people have died. This is nothing to be taken lightly. There's only 2.8 million deaths per year in the United States, and this is in addition to that. So it's a very lethal disease that fortunately only kills about 1%. I mean, that's a low percent, but 1% of 340 million people is 3.4 million people. So we don't want to do that. And the treatments are getting better. The vaccination rate is going up. All these things are pointing in the right direction, but we've got to get our public health approach aligned and protect as many people as possible.
Yeah, absolutely. And for some viewer questions, first one, I have a rare autoimmune disease, muscle disease, and neuromuscular restrictive lung disease similar to ALS, and I desperately need to be vaccinated. However, I have an anaphylaxis to PEG, so I cannot have Moderna or Pfizer vaccine. I know that J&J has polysorbate, but I don't know if this is related to PEG. Is polysorbate and anything else that I have been exposed to? What do you recommend for this individual in terms of being vaccinated and what they should do?
Yeah, fortunately, these kind of situations are very rare. And what I would recommend to anyone who's allergic to PEG or polysorbate or any of those ingredients in there, first of all, it's a very few people, but if you have it, it's very serious. Get in the hands of a good allergist at your hospital or referral center. Review the options that you have. Certainly if you get COVID, of course, it's, much worse than any, problem you'd have with the vaccine. So in this case, maybe the Johnson & Johnson vaccine is the way to go. The other thing to keep in mind, besides getting good allergies, make sure that your vaccine is given in a hospital setting, not a pharmacy, not a clinic that's geographically disconnected from a hospital. Because if you have anaphylaxis, you need all the appropriate equipment around and expertise to treat it. Everybody does not die from anaphylaxis. Matter of fact, I don't know if there's been any deaths from anaphylaxis from the vaccines. It's a serious reaction, but it can be treated. So just be in good hands and get some expert specific advice.
Great. And for question number 2, there are 12 women in a book club ages 50 to 90 who are all vaccinated and would like to know if it's safe for them to meet inside without masks.
Well, it's great that they want to get together and that they're all vaccinated. That's a step in the right direction, but you got some people there that are elderly, and probably the safest thing is that you still wear masks and stay 3 to 6 feet apart at the meetings.
Great. And these individuals, so the third question, these individuals are fully vaccinated and do not have any underlying health or immune issues, and they do not work in a health setting. So since IDPH requires masks to be worn indoors in public, does in public also mean at a private residence, like at a friend's or family member's home with people outside of our apartment bubble? What can you tell us about in public required masks?
No, so in public is in public, a public place. Your home is your residence. It's a private residence. You can do whatever you want. To be the safest, you should limit gatherings in your home to people that are fully vaccinated, and keep your bubble safe. So that's a personal decision. The risks. If everybody's vaccinated and you're not at a high risk place, you're like right now, the situation would be different if you were in Minnesota, Guam, or Anchorage, Alaska, where they're having a terrible problem. That would be kind of a different situation. But in most of the country, the numbers are going down. So everybody, you have to, define what your safe bubble is, and your private residence is your private business.
Awesome. And for a follow-up to this question, if one of them chooses to be unmasked in a private residence with family or friends, do they need to be tested, or do they follow CDC guidelines and only get tested if they show symptoms or someone in their bubble tests positive?
Well, I think kind of it's the same answer as what I just said. You wouldn't have to get tested unless you had some symptoms for the most part. And you can get the over-the-counter ones, and you're supposed to do more than one. So at least 2 of those, 36 to 48 hours apart. You don't have to go off and get a big PCR test at the hospital. That wouldn't be really necessary at this particular point. However, if you're in a high-risk place, you would even consider doing tests in people that didn't have symptoms. But really what we're talking about here is get tested if you have any kind of symptoms at all. Even if it's like a mild, just sniffles or a sore throat or something, or a little cough, even without a fever, then you definitely get tested.
Wonderful. And the last question is regarding Africa with COVID. Can you tell us about the not large outbreaks that we're seeing in Africa and the difference of how it was handled versus Europe, South America, and India?
Yeah, the Africa story, I work in Africa. I know the situation fairly well. Very few people are vaccinated. It's well under 5%. And that's starting to change now. But they have not had the big outbreaks that were predicted. And there's a couple theories. We don't really know if they're correct. They're just theories. One is that the African population is very young. So even if they got infected, they would probably have mild disease and maybe not even being picked up. So underreporting, young population. Another theory is that the Africans are exposed to a lot of non-COVID coronavirus infections more so than we are here. And so maybe they have some built up immunity that other populations don't have. And, perhaps it's a genetic issue where, they're able to handle the infection or prevent it better. These are all just theories that are thrown out there, but definitely the numbers in Africa are lower than what was anticipated. They still have some high areas. South Africa in particular has a very good reporting system, and they have epicenters within South Africa, so that's bad. But the other thing is, and we don't give them enough credit for, is that when many of the countries put in anti-COVID mitigation strategies, like lockdowns and closing certain businesses and ports and whatever, they actually did a very good job with that. And so, they were able to blunt what problems they had in many of the cases. They were much more coordinated, say, than we are here, where we have some states that are banning mandates and some states that are mandating all sorts of things. So, it just is, it's kind of a surprise, but they're doing fairly well.
Well, that's wonderful. And those are all of our viewer questions today, and those were all the headlines. Thank you, Dr. Murphy.
Okay, thank you.